I'd like to welcome you to the South Asian Health Foundation, or SAHF as we're known, to the Mental Health in Times of COVID webinar. My name is Kiran Sehmi. I am a trustee at SAHF and I will be chairing this evening's webinar. I'm delighted to be joined by such an expert panel this evening, and also some of our SAHF fellows. So the schedule for this evening is that we are going to be joined by an expert panel comprising of Anita Solanki, who is a mental health training programme director across the north of England, by Director of Public Health Sally Burns from the London Borough of Newham, and colleague Deepa Ladd, who is a public health specialist, and they're going to be doing a bit of a double act. And then we are delighted to be joined by Anisha Chauhan, who is one of the SAHF fellows, who is going to be taking us through some work that she has led on in regards to the COVID crisis in India. I'm delighted to have GP Dr. Amal Ladd also join us, who will be sharing some perspectives in terms of the impact of mental health across primary care. So without further ado, I would like to thank you, the panel, for giving us their time this evening. There will be 4 presentations, and then there will be an opportunity for a Q&A session at around about 8 p.m. And then we will aim to complete the webinar by 8:30. So can I please welcome Anita Solanki?
Thank you very much, Kiran, and thank you for inviting me to speak this evening. I'm going to take the liberty as a pharmacist to share some of the updates as regards pharmacy, just in case you're not aware, because we're embarking on some changes in terms of our profession, how we are going to educate our future pharmacists. And I thought that might be useful information for you, because potentially it will impact on how the services operate and how they might work with you as professionals as well. So I'm just going to share my slides. I'm hoping everyone can see that in the screen view. So I'm going to speak about mental health in times of COVID, but as I say, I'm also going to speak about pharmacy. So as Kiran said, I'm the mental health training programme director for Health Education England across the north of England, but also working on some national projects as well. Alongside that, I'm a lead pharmacist in Leeds and York Partnerships Foundation Trust. So what I'll do this evening is share some of my experiences and my observations wearing both of those hats. So I'll kick off with the pharmacy team. Again, some of this you may be familiar with, but just in case you're not, I thought it was useful to share this with you, because sometimes we need to understand what the pharmacy team is made up of, because sometimes the roles of the pharmacy team, actually you might want to speak to somebody else within the pharmacy team rather than the pharmacist. For general information, the General Pharmaceutical Council regulates all registered pharmacists and pharmacy technicians working in Great Britain. So for pharmacists currently, it's a 4-year degree with a 1-year, what we call pre-registration training year. That's up until next month, which then totals 5 years in training. And the pharmacist's role really is to make sure that we optimise the medicines, so that we use medicines safely and effectively and appropriately, that we're using the right medication at the right time. And obviously pharmacists operate in different sectors of practice. I myself have had experience in secondary care, primary care, academia and industry. So there's plenty of opportunities for pharmacy practice. We need to work with our pharmacy team members. So we work closely with pharmacy technicians, and they undertake BTEC qualifications or NVQ level 3. Usually takes up to 2 years, and within that they have some experiential training as well. So they learn a lot more on the job than we perhaps do at the moment. The pharmacy technician's role is to help with medicines reconciliation, to make sure that we've got the right information for patients in terms of the medicines that they're taking at the moment and which medicines that they don't take, just to make sure that we don't inadvertently give them the wrong medicine. They also help us with counselling individuals on the medication to make sure that we're giving them the right information so patients can make informed choices about what they take and how. And then the people that we rely on heavily are our pharmacy support workers, and they're our colleagues who work within the dispensaries primarily to dispense the medicines, to put the medicines in the bottles, to give to patients and to customers in community. So obviously I'm going to speak about this from the secondary care lens, because that's where where most of my experience lies. However, the roles are quite similar across primary care and community settings. I'm going to look now at the workforce in relation to diversity. I've taken this information from the General Pharmaceutical Council and some surveys that have been taken as well. So again, looking at the same staffing that I've just spoken about, we've got 43% of the pharmacy workforce are from Black, Asian and minority ethnic communities. That perhaps doesn't surprise you. I know pharmacy is a very much favoured occupation within sort of Asian cultures. It certainly was for me anyway. We see that across the sectors as well. So across community, primary care and hospital settings. What we also see is it's predominantly a female orientated profession as well. We have obviously lots of females who use the opportunity to be able to manage their work-life balance and have families as well as practice. Not that it's an easy combination to have, but it seems to work quite well. We have quite a number of new roles again within pharmacy. So I'm not going to explore those in detail today, but just to mention that we are working within sort of care homes in primary care settings as well. So the makeup of pharmacy professionals there might be slightly different to what I've just described now. But it's really important that we recognise that the pharmacy team, each of them have their distinct roles, and therefore, you know, in terms of what you need from the pharmacy, you might be able to speak to the pharmacy technician, for instance, as well as the pharmacist. So I alluded to some changes in pharmacy education, which will kick off from July of this year. So traditionally, we've had the pharmacy degree, which is a 4-year bachelor's degree, or master's degree, and that's finished off with a year of pre-registration training, which is usually in community or hospital, or some, excuse me, some joint placements that some people undertake. So you'll spend 6 months of the year in one setting and 6 months in another. What we're changing to now is a more clinically focused undergraduate and foundation training program. So what will happen is the trainees will start with the degree course, and from day one, essentially, they will have more clinical involvement as in their training, probably similar to what medics do and other healthcare professionals. And what that means is that by the time they qualify, coming into practice won't be so much of a surprise and very different to what they've experienced up to date. And that will be a really positive thing, because at the moment in pharmacy practice, I think there tends to be a little bit of a difference, i.e. within hospital settings, it's perhaps more clinically focused, i.e. we work within the multidisciplinary teams and we have more involvement with patients in accessing records and being able to follow the patient journey, perhaps a little bit more than currently happens in community and primary care. However, these changes to pharmacy education should hopefully address that and make sure that we've got some more consistent training across the board, so the pharmacists that come out from their degrees are able to work in any of the sectors that they choose to, which will obviously benefit patient care. The other point there is that pharmacists can currently undertake non-medical prescribing qualifications to become prescribers, but this change in the pharmacy education will mean that the pharmacists at the end of their degree will be able to prescribe from the first day of registration, which is obviously a new change and will have impacts on their service and the way that they operate within their particular setting. I'm interested to hear from any GPs on the call as to their views about that. What we try to do within pharmacy practice is to work collaboratively. We want to make sure that the pharmacy service represents the populations that we serve. Previously, I showed you the diversity information, and more often than not, I think we do have a good mix, but there are some gaps in terms of the diversity and the recognition, I suppose, of the different roles that people have. And so there is some work to do in terms of making sure that all the pharmacy professionals across all sectors are providing the same quality of high quality of care. We need to use the pharmacy staff better, and that's why I've mentioned the different roles of the pharmacy team today, because we are able to use our pharmacy technicians to do much more patient-facing work than perhaps we traditionally used to. And obviously that will benefit patients as well. And we certainly do that within the mental health setting, which is where my current practice comes from. What I have found out as a result of some of the scoping work that I've done within Health Education England is that pharmacists and pharmacy technicians really do have limited exposure to mental health services during their training. And that can have huge repercussions in terms of stigma, in terms of their confidence and competence to be able to manage individuals with mental health conditions. What we also aim to do is to continue, which we've always done, is to look at health promotion, not reactive, but proactively, to enhance the diet, the exercise, to make sure that we're giving that full range of healthy advice, not just medication. And sometimes it might be about not using medication, because medication might not be the answer to their problems. So moving on to the impact of COVID on pharmacy. This information was taken from the Pharmacy Support Service, which obviously has been very busy as a result of the impact of COVID. And I know my community colleagues and pharmacy colleagues in particular have been really in the front line of supporting the COVID response, and I thank them for that. A third of the pharmacists there have reported that it severely impacted their mental health and well-being. Obviously, the workload has increased, the intensity and the acuity of their work has also increased, as has that in secondary care. We've got a considerable number of respondents who consider themselves to be at risk of burnout. Now, that was obviously November 2020. I would say that still is the case, certainly within the services that I operate within too. Within the workplace, we've introduced risk assessments, which have been variable in terms of uptake, and also the relevance to individuals has been challenged. However, I think if the opportunity exists to have a conversation with staff, colleagues, peers, then let's take that opportunity. And I know it's been prioritised for Black, Asian and minority ethnic communities, but again, I think there has been some reluctance, some resistance, i.e. it's a tick box exercise and what will this achieve? But as I say, I think the point really is about the conversation and the protected time to do that. But more worryingly, from that survey, we understood that 45% of Black, Asian and minority ethnic pharmacy professionals were unaware of the occupational health services. It doesn't tell me which sector that is, and I'm aware as secondary care services do have occupational services as well as primary care. My assumption is that it's possibly within the community and primary care settings, where we need to make sure that we're supporting our colleagues there who are really obviously facing the brunt of the impact of the pressures of mental health. I mentioned community and primary care settings there in terms of impact, but we in secondary care are noticing a significant increase in referrals to our services, regular full bed states, and it's obvious why that's the case. But what we know is that we can't always manage those individuals within the specialist services, and perhaps we don't always need to. So it's really important that we support our community and primary care colleagues to be able to manage individuals with mental health conditions. What we see more of is an increase in the stress, anxiety, depression presentations, generally across all age groups, but we do see them in older adults particular, and also in the younger child and adolescent populations for whom the pandemic and lockdown has had a huge impact. We also see it more in those with underlying health conditions. and perhaps as a result of them being particularly more vulnerable to the COVID infection. Within the mental health services, we know that the mental health medicines that we use sometimes can predispose individuals to developing long-term physical health conditions, whether they take medication or not. So we do need to really understand the close link between physical and mental health and try and address both of those equally. So what I'd like to share with you now is some of the projects that I've been leading whilst I've been working with Health Education England, which basically sort of try and address some of the issues that I've raised in the slides before. So hopefully you can follow this. The projects hopefully span all of the pharmacy professionals, and at the top, on the top line, we can see the different career grades. So we've got the undergraduate, the pre-registration, who are now becoming foundation pharmacists as of July. But this year, as a result of the COVID, where the registration exam was postponed, we developed a new cohort of staff called provisionally registered pharmacists. Obviously, the foundation pharmacists are their newly qualified pharmacists, usually up to 1,000 days after registration. And beyond that, we've got advanced pharmacists, and beyond that, consultant level pharmacists. So the first project I'd like to talk to you about is the Core Mental Health Competency Framework. And the link on this is on the screen there for you to access that. It's under the Mental Health tab. And this is the project that I led before, it started before the pandemic. And we did some focus groups and we did some evaluation, and then we hit April 2020 and we had to make a decision about what to do, whether we continued with it or not. And we felt that the need for mental health support across our practice areas was going to increase inevitably, and so we continued with it. And it was a really collaborative piece of work. I was involved with pharmacy professionals across all sectors and different professionals as well to understand exactly what we need to consider when we're having a conversation with somebody who's got a mental health condition. And that's not to stigmatise individuals, but it's to make sure that we've got everything covered, that we're not making any assumptions, that we're not making any judgments, that we're having an open, transparent conversation, and we recognise some of the factors that we need to consider. For instance, insight into the condition, consent to having these conversations, willingness, acceptance of medication, what underpins that. So there's a number of domains within the framework, which the intention is that you could use to develop your own continuing professional development. You could take a domain and work within a group and do it that way. We are embedding that within the initial education and training, so within the new pharmacy programs that I've mentioned previously. I know it's being used in pharmacy, in inductions within hospital settings and within community settings. So it really is something that hopefully people can take hold of and use and gain some meaningful learning from it. Obviously, it's related to pharmacy professionals, but I do think there would be some overlap with other professionals using the framework as well. Another project that we worked on was to look at the experience opportunities, because it's a bit of a catch-22. If you've never had experience in a certain setting, you wouldn't think to work there. You might have some fear and anticipation about working in a particular specialist area. And so we want to understand nationally what that looked like. We are in the process of finalising the paper ready for publication. But I suppose the key highlights from that were that early experience, and that perhaps applies to other professions, really does impact on future career decisions and where you end up. I know for me, certainly I had some early experience within mental health, and it had a profound impact on me in terms of, yes, I can use my pharmacy knowledge in a bespoke way here to make sure I'm using the right medication for that individual at the right time. Went off and did other things, but came back to it. And some of my esteemed mental health pharmacy colleagues, the same has happened for them. We also know that where you get that experience can sometimes be challenging. So a lot of people want to gain experience within mental health specialist settings, and we know that isn't always possible. But equally, we know that mental health doesn't just exist within secondary care. My pharmacy colleagues within community and primary care settings will also be managing individuals with mental health conditions. So an opportunity exists that I see for developing experience within those settings as well, to make sure we are upskilling our staff to be able to look after individuals with mental health conditions to a point, not to make them specialists, but to know that they can manage them so far and then signpost and refer on as necessary. We also looked at extended roles, so for the advanced consultant level practitioners. So when I first started in pharmacy, we didn't really have many extended roles. We were very much dispensary based. We were very much not so much patient facing, but that's really changed over the last few years. And obviously changes to pharmacy education will make those changes even more significant, which is a really good thing. So that survey just tells us the sort of the transformation that's happened in our workforce, and you as well may have witnessed that in terms of your practice. Project that I'm working on at the moment is the Mental Health Champions, and the next slide I'll talk about that in a bit more detail. And I'm also looking at developing the training pathway for the specialist mental health pharmacists in community settings, which is working with NHSEI and workforce transformation leads across the country to ensure that if we are looking after individuals in the community who've got specialist mental health needs, to make sure that our staff are appropriately skilled to do that. So just touching on the Mental Health Champions project that I mentioned, we know that the care of mental health in acute settings isn't good, and it could be improved. There's a number of papers that have supported that. The Treaters 1 from the National Confidential Inquiry into Patient Death in 2017 identified that there were some massive gaps in terms of the care that patients received, incomplete records, for instance, lack of appropriate management when patients were admitted there. Since then, I've worked with a group in the Northwest, pharmacy group, acute pharmacists and mental health pharmacists, to develop the strategy paper, Working as One, where we try to define exactly what we need in terms of mental health champions. What is that gap, and how can pharmacy address some of those issues? So I've been working regionally with transformation leads and chief pharmacists and other key stakeholders to try and understand the priorities from the acute trust setting in terms of mental health management. What are the gaps, and what support can we as mental health specialists provide for them? So at the moment we've identified some project managers. So I've got some mental health pharmacists who are in reaching to the acute trusts to make those initial links, because for some acute trusts, they don't even have links with the mental health trust in their locality. And then we're going to try and understand what the priorities are and develop some training in order to upskill those acute pharmacy staff to be working as mental health champions alongside their existing roles. So again, to be able to limit those medication errors that occur when patients come into the acute setting, to avoid the lithium being stopped for no obvious reason, to avoid the clozapine being missed for 48 hours and then requiring a retitration, which obviously then can result in further consequences in terms of management of care. So we're midway through the project within the Northwest, and we have just started that in the Northeast and Yorkshire. So more information to follow as regards that. And then I wanted to sort of just, I guess, summarise some of the hints, tips and resources that I've come across as I've done these various bits of work. So I touched upon the wellbeing assessments before, and as I say, there's some individuals that don't really think that they're necessary, but I think some of the survey results that I've read, conversations that I've had with individuals, I think it's the protected time and the line management and the clinical supervision that has been really positive for staff in terms of managing their wellbeing and mental health, and we must prioritise that for ourselves and for our colleagues. Again, knowing what our early warning signs are, because we're all busy and sometimes we don't do the right things for ourselves as well. So just a little reminder, you know, if we're not sleeping too well or we're not able to differentiate work from home, and particularly when we're working from home, it can be challenging. So we just need to be quite strict with ourselves sometimes and look after ourselves in that way. I've also just put some MindEd top tips. So these are from obviously from MindEd. Again, useful resources that sometimes we forget, but probably could do with refreshing ourselves with. Connect 5 is a program that I worked with within HEE. Again, some really useful resources, primarily aimed at community pharmacy colleagues, but again, relevant if you're in primary care, for instance. And the last point on there is about choice in medication. So this is a resource that we use, a patient information resource about mental health medicine. So obviously the BNF would be something that we go to, but it sometimes doesn't give us the detail that we want. So I know some mental health trusts have signed up to choice of medication. It's a really good resource to access for back conditions, but also medication. And general information that patients would find easy to read. And there's also leaflets in different languages and different font sizes as well to address any challenges that individuals might have in terms of accessing the information. I always like to mention 5 ways to well-being, because again, you know, we don't always do this. I'm not going to read the detail, but hopefully you will. And take some of these tips away with you as well. And as it's meant this week's Men's Health Week, I wanted to just finish off with a short video. Kiran, have I got time to share that? Yeah, okay. So I'll try and share that with you now. Just to say, I appreciate not everybody will understand the language, but hopefully you'll understand what's happening in terms of the actions. And it's really sort of recommending turmeric. Enjoy.
દેશી ઉપચાર હું બતાવું છું તમને. મારો જાત અનુભવ છે, અમારા ફેમિલીનો ઘણા લોકો મિત્રોનો. આવી રીતે ગેસ ચાલુ કરવાનો, બરોબર. મારે ઓલરેડી 5 મિનિટ થઈ ગઈ છે. આ રોટલી બનાવવાની લોટી છે. એમાં જે બાજુ આપણે રોટલી નાખીએ એ જ બાજુ આપણે ઊંધી અને ગેસ ઉપર ફ્લેમમાં મૂકવાની. 5 મિનિટ મૂકવાની, બરાબર નહીં તપાવવાની. અત્યારે તપી ગઈ છે, 5 મિનિટ ઓલરેડી થઈ ગઈ છે, એટલે હું ગેસ બંધ કરું છું. અને એમાં આ રીતે નમક નાખવાનું, ભભરાવાનું, બરોબર છે. આવી રીતે આની ઉપર હળદર નાખવાની, બરોબર. અને આ રીતે આવી રીતે આમ કરી આ દિવાળી ઘરના તમામ સભ્યોએ લેવાની, જેને કોરોના થયો હોય કે ન થયો હોય એ બધાને લેવાની. આ પાછું કાળું થઈ જાય એટલે ફરીથી આની ઉપર થોડી હળદર નાખીને બીજા જે બાકી સભ્યો હોય એને લઈ લેવાની. મોઢું ખુલ્લું રાખીને અને નાકથી પાણી આવી જાય આંખમાં, બરોબર છે. ફૂલ એકદમ છાતી ફૂલે એ રીતે આને ધુમાડી લેવાની, બરોબર છે. બધા ઘરના સભ્યોને બાજુમાં ઊભા રાખી દેવાના. પછી આ માથે હળદર મીઠું બબડાવવાનું. આનાથી તમારે કોઈ પણ કોરોના પ્રાઇમરી સ્ટેજમાં હશે, વધારે વધારે 2 દિવસમાં જતો રહેશે. સવાર, બપોર અને સાંજ આ વસ્તુ જેને કોરોના પોઝિટિવ આવ્યો હોય અને લક્ષણ દેખાતા હોય એને કરવાનું. અને જે લોકોને બીજો કોઈ પણ ડોક્ટરની દવા ચાલુ હોય, ઉકાળા ચાલુ હોય, બધું ચાલુ રાખવાનું. પણ આ વસ્તુ કરવાનું મારો પોતાનો 2 વર્ષનો અનુભવ છે. ગયા વર્ષે પણ મને પોતાનો કોરોના હતો. એમાંથી મારે હોસ્પિટલમાં જવું ને મને 40% કોરોના હતો. 30 થી 40% મારે હોસ્પિટલ જવું પડ્યું નહોતું, કારણ કે સવાર, બપોર, સાંજ આ દિવાળી મેં લીધેલી હળદર મીઠાની. અને બાકી ઘરના સભ્યોને પણ 2, 3 થી 4 દિવસમાં કોરોના જતો રહ્યો હતો. પહેલા મને આવ્યો હતો, પછી બધાને આવ્યો હતો, બરોબર. આ વર્ષે પણ મારા ઘરના સભ્યોને એકને કોરોના જે ગયા વર્ષે બાકી હતો એને આવ્યો. બાકીના બધા સભ્યોના દિવાળી લીધી, કોઈને કોરોના આવ્યો નથી. બધા સ્વસ્થ છે માતાજીની દયાથી, બરોબર. આ ડોક્ટરની કોઈ પણ દવા ચાલુ હોય ચાલુ રાખવાની. અને વધારાનું આ આટલું અચૂક ભૂલાય નહીં મિત્રો. આપણા સ્વાસ્થ્ય માટે છે. સૌ સલામત રહે. માતાજી સૌને સલામત રાખે.
Thank you. So he was recommending the benefits of turmeric and salt if you have coronavirus or risk of having coronavirus, because it really helped him. So there's your Men's Health Week tip.
Fantastic, Anita. Thank you so much for that. And there are some questions now we'll come back to. So moving swiftly on, can I introduce Sally and Deepa, who are going to do a bit of a double act for us, and they are from the London Borough of Newham.
Hope you're well. My slides on. Yes, my name is Deepa Ladd, and I'm one of the public health officers at Newham, and I will be joined with my colleague Sally, and we'll be basically talking about the COVID-19 recovery plan and the mental health in Newham. So we'll be covering a little bit about Newham as a borough, the impact COVID-19 has had on the mental health of the residents, and then Sally will talk a bit more about the mental health and wellbeing impact assessment that we carried out and the next steps that came out from that review. And then I will briefly just go over some of the mental health interventions that we've implemented. So about Newham. So Newham has a population of around 360,000 people. It has a large proportion of Newham's population is within the 20 to 39 age bracket, so it is quite a young borough. And actually the proportion of our residents who are aged 24 years or younger is the highest within London. We also have a hugely diverse range of languages with more than 100 different languages spoken within the borough. So obviously this does create a significant language barriers when we're trying to implement new interventions and services. And the 2011 consensus data actually showed that nearly 9% of Newham residents are unable to speak English well or at all. And this is almost double the value of that of London in general. So as we said, Newham is a very diverse borough with over 70% of the overall population from different ethnic groups. So to contrast, for London as a whole, the proportion of people from ethnic groups is only 41%. So it is a very, very diverse borough. And Newham's largest ethnic group is Indian, but also the Bangladeshi, Pakistani and Black African populations are all proportionally much higher in Newham compared to that of the other London boroughs. And in terms of the white British population, it only accounts for 15% of the residents in Newham compared to around 40% for the whole of London. So in terms of mental health in Newham, it tends to be quite poor compared to London and England, with depression and anxiety being the most common disorders. So as you can see in this graph, in 2017, the prevalence of common mental health disorders was significantly higher in Newham, as you can see, compared to that of England. And Newham at that point was considered to be the second highest borough in London for common mental health disorders. However, on this graph, you can see that the recorded prevalence for depression in residents aged 18 and above showed to be Newham as the lowest borough, significantly lower than London and England. However, we think that this might reflect the higher levels of stigma in terms of reporting and discussing mental health disorders within some of the ethnic communities within that borough. So the impact of COVID on our residents' mental health has been quite negative actually. So as you can see, at the beginning of the first lockdown in March 2020, the number of calls to our crisis lines and the number of face-to-face assessments dramatically increased. So COVID and the pandemic has had a detrimental effect on the residents' mental health. So I shall pass it on to my colleague Sally, who will go through the next few slides.
Hi everyone, so I'm Sally Burns. I'm a public health consultant in Newham, and I've been working with Deepa on this project. So just to explain, as part of our recovery plan from COVID, we set up a mental wellbeing partnership as part of our sort of emergency structure. It was made up of partners from across the borough, from the local authority, from the health system, and also from the voluntary sector. And as the pandemic started and at the height of the pandemic, that group was actually meeting weekly. What we wanted to do, we saw and we realised that there would be a significant impact on mental health and wellbeing, and we really wanted to work together, maybe in a way that we'd not done before, work together really strongly and understand the impact. So we were looking at pressures on services. We were bringing in intelligence from different communities and different voluntary sector partners just to try and work out what the impact was going on, really. Can we go on to the next slide, Deepa? Thank you. So we could see from the increase in demand on the different services, from the number of sort of job losses that were going on in the borough, and the sort of people who were attending our money work service, which is, offers support to those who are struggling. And as Anita was saying earlier, we could see, particularly with those who already had, long-term health conditions, we could see a really significant impact on them as well. So what we decided to do as a partnership was do something called a mental wellbeing impact assessment. So to work as a team, basically, to carry out a piece of work to really understand the impact of the pandemic on our residents in the borough. We used a methodology which was produced by it was published in 2011 actually, so it's quite an old methodology now. It was produced by something called the Mental Wellbeing Impact Assessment Collaborative, and I'll put the link to the guidance in the chat, so if people are interested in that, you can take that away. But basically the process involved us working as a team across all those different organisations. We produced a profile for the borough, a sort of mental health and wellbeing profile, and we added to that the sort of intelligence as it was coming in on demands on services. So we did the data collection. We had a series of stakeholder workshops, which we called Working Out Loud. Basically, all our different colleagues and service users and representatives from different groups went through a series of 4 workshops where we threw in our knowledge, threw in evidence, and tried to consider the impacts on people. We did a bit of a literature search and an evidence review, but I mean, in hindsight, I personally think that's something we probably need to do again, because at the time there was very little information, very few studies that had been sort of authorised around the impact of mental health from the pandemic. So I think in hindsight it would probably be best to do that again, really. And then we went through a process of identifying the sort of positive and negative impacts of the pandemic on our residents. We found lots of negative, as Deepa said, but we also did find positive, and the positive impacts were very much around that sort of communities coming together, communities working together on this to try and help each other, and that's something that we've really tried to sort of build on in our planning. And the last stage of the process was to bring a report together and some recommendations. So we had 12 recommendations, and the big part of that was the recognition that there were some people that were significantly impacted more than others. So the groups we recognise were some of those groups that Deepa mentioned, who are more isolated in Newham, particularly young people like carers, people who've already got sort of long-term conditions and things. So so can you move me on to the next slide, Deepa? The key themes. So the key sort of wellbeing impacts, first of all, around were sort of, as you see on the slide, anxiety, loneliness, trauma, and things like that. And what we did as a borough was put in additional services. So we put in additional befriending support in communities and things, recognising that not everyone needed sort of a sort of clinical intervention. You know, there was additional support that we could also put in communities. This is for both children and for adults. The study helped us really think about the contributory factors and try and look at some of the challenges through that lens as well. So, you know, things like some of the housing challenges and people losing their accommodation because of loss of income. Social media was a massive factor in increasing anxiety and things. So we really thought as a borough about how we were communicating and things. I've mentioned that we saw certain groups being disproportionately affected, and our plan is based around that, and Deepa's going to talk you through some of the things that we're doing now. And you know, we in terms of the mitigation, I said that, you know, we saw very much that there was sort of a community level response that we could strengthen, as well as supporting some of the clinical services and things. So I'll just talk quickly about next steps. So we developed a plan from the study that's sort of available on the council's website now. If people are interested in that, I can put a link in the chat as well. But what we are moving on to using that is a new mental health and wellbeing plan for the borough, for the whole system in the borough. We have made a commitment to sign up to the Public Health England Mental Health Concordat, Prevention Concordat, which basically you know, is taking a sort of prevention approach across the whole system. Our new health and wellbeing strategy was launched back in November, and one of our ambitions in that is for Newham to be a mental health friendly borough. So that, you know, we see that journey really supporting that. And then finally, I'm sure like many other areas who have got these challenges in the country, we got some Public Health England mental health funding just recently. We're still waiting to hear actually if it's been finalised, but what we have done is wrap that money around some of those community projects that Deepa's going to talk to you about now. Okay, thank you.
Thanks, Ali. So yeah, so I'll start off with some of the initiatives that we've got for the children and young persons' mental health. So we had some open workshops focusing on stress and anxiety for young children across Newham. So we had about 90 children attend of mixed ethnicities. Around 60 of them were aged between 8 and 13 years, and the remaining were about 14 years. And the session was delivered by KUTH, which is a organisation, a digital mental health organisation within London. And we got very positive feedback. You know, the children engaged well with the workshop, you know, and they found it very helpful in coping with their anxieties and stress around school and the pandemic. However, we did have feedback to say that, you know, any workshops we deliver moving forward, that we break down the age groups. So, for example, have one for 8 to 10-year-olds, 11 to 13, and 14 and above, just so that the conversation is a bit more concentrated and the children feel a bit more safe to share some of their struggles. Another workshop that we ran is as part of our Thoughtful Thursday initiative was for parents, so helping them to cope with the stresses of working from home and also homeschooling. We had about 120 parents attend, which is fantastic. And we spoke mainly about how to support their children as they return back to school, and also shared some self-wellbeing advice for parents. So we had a short meditation yoga session at the end for about 10 to 15 minutes, which I think the parents found very useful and relaxing. So that's what we had for the children and young persons. In terms of the adults' mental health workshops, we tried to create some culturally sensitive workshops which are targeted for specific ethnic groups. So we co-produced this with Newham Talking Therapies and also with the key community members from each of the ethnic groups. We ran 2 pilot sessions, first with the Newham Muslim Forum and another with an organisation called Heal Together, which is a Somali organisation. And the predominant thing was to have psychoeducation, basically addressing the specific needs within the community. So for example, for the Newer Muslim Forum, the workshop was delivered by a CBT therapist from the Muslim background. And we also focused on how to maintain good mental health and well-being during Ramadan. So some self-care tips and, how to cope with anxiety and stress, when you can't eat or drink or do any proper physical activity to relieve stress. So we spoke more about that. And for the Somali organization, we received a lot of feedback that there's a lot of trauma and PTSD experience within this organization. So aside from depression and anxiety, we really focused on noticing the signs and symptoms of PTSD and the services that are currently available where they can go and seek help. However, as with any pilot, there was some feedback we got from the people that attended, and essentially we weren't able to penetrate deep within the community as we intended. So the workshops were designed for the residents themselves, but the people that attended were actually people who had an investment in mental health and wanted to further their knowledge. So the workshops that we provided were quite basic, and so they didn't really gain any value from that. We also found that psychoeducation is not necessarily needed. And what is needed is, in fact, mental health training and mental health first aid. So the people that attended these workshops expressed an interest in actually running the workshops themselves, therefore eliminating any language or cultural barriers. And they could directly address people within their community themselves as and kind of removing the clinical kind of local government aspect of that, so that they had an open space and there's already trust built within the community members. So this is what we're trying to incorporate now and adapt to the workshops to kind of upskill prominent community members and faith leaders. So training them in active listening, understanding body language, and the different avenues that they can signpost people to the relevant services. And finally, we just wanted to share some of the work that we've done with Good Thinking. So we've partnered with this organisation to create this materials about mental well-being within the Muslim population. So essentially, we've taken Islamic teachings and culture and incorporated them into the 5 ways of well-being, which Anita mentioned earlier. So we've got connect with Allah and with people, be physically active, learn something new each day, give to others, and pay attention to the present moment. All the materials have been endorsed by the Muslim Council of Britain and BEMA. So we have leaflets, and we also have social media, infographics and videos from various prominent Muslim figures within NUM. And we released this just after Ramadan. And we had a very good response to it. And all resources have been translated into multiple languages, including Hindi, Gujarati, and Somali. And I think that we are now trying to adapt the 5 ways to well-being to Hinduism, Sikhism, and I think Christianity as well. So here's just an insight into what the leaflet looks like. So on one side, you have the way to well-being, and all the infographics are very culturally relevant. And on the other side, we have quotes from the Quran that directly relate to the way of well-being. And we also have ways in which people can go about doing this. For example, spending 5 minutes reciting or listening to the Quran daily. And this will help them to build a sense of belonging and self-worth. So it just makes the resources a bit more relatable. I can put a link to the resources in the chat so you can have a look and use at your own leisure. So yeah, that's the end of our presentation. Thank you for listening.
That's wonderful, Sally and Deepa. Many thanks for that insight. There have been some questions that have popped up in the chat, which we'll come back to at the Q&A. So our final presenter of this evening is our SAHF fellow, Anita Chauhan, who is going to talk to us about some of the work that she has led on in terms of the COVID crisis in India. So Anita, over to you.
Thanks so much. I'm just going to try and share my screen, which hopefully you can all see and hopefully you can all hear me. Otherwise, I'm sure someone will say. But yeah, so hi, I'm Anita. Thanks for the introduction. And this is some work that I did with some of the SAHF fellows about the infographics that we made for the COVID-19 UK webinar series. And this is just a little bit about kind of what we did and why, essentially. And so if you can hopefully see the slides, but essentially we started this in April because of the rising number of COVID cases that we could see in India. And just a bit of an example, just a reminder of what was happening at the time. So this is a graph from the BBC that you can see COVID cases and deaths in India up to, I think, the 2nd of May. And the blue line is the 7-day average of cases, and the red line is the 7-day average of deaths. And I think you can see that when we were experiencing our own kind of second wave back in December, January, there wasn't really the evidence or the news coming out of India suggesting that they were experiencing the same. But this changed in March, when actually you can see that both the blue line and the red line both go up dramatically. And this was associated with some pretty terrifying headlines at the time. So we were hearing about oxygen shortages, bed shortages, about kind of overwhelmed staff. And I think that all of us, kind of from our own experiences, we've been concerned about things happening here like that. I mean, we only really narrowly avoided some of those things, and we definitely experienced some of them. So I think the general consensus was that, or the collective feeling was that we wanted to try and support as much as possible. And so the question came as to how can SAHF support the COVID-19 crisis collectively? And the trustees made this 10-point plan, which kind of helped categorize what kind of help should and could be offered. And as you can see, it's a multifaceted approach. So it needs to kind of span all sorts of different areas. So from vaccination and supported isolation to population health management advice to government kind of mobilization. And really, I mean, there was a lot of different options of kind of how to do things and try and work out who was best to do what. So the next question was, what could the SAHF Associate Fellows do? And just as a recap, so we're a fairly new group. We've all got healthcare backgrounds, all have a variety of interests. But I think one of the things that we all have is an interest in addressing health inequalities. And so when this happened and the 10-point plan was made, the question was, how could we support the 10-point plan? And I think that in terms of what we could do, so we felt well placed on discussion about kind of what we felt well placed to deal with the academic and the media mobilization, and thought that that was something we could help with. And I think from discussions that we had, we thought that one of the most important things to mention was that the pandemic had highlighted the importance of international collaboration. And that was important for us, especially in our own first wave, when we relied on the experiences of Italy and other countries to help plan our own response and develop guidelines. And the other thing we kind of noted was that there was a lot of misinformation going around, and we thought that it was important that SAHF continued to be a trusted source of information, with all the information that was made to be available in accessible formats for those on the front lines in India. And so whilst we were discussing all of this, the SAHF trustees were busy making an amazing series of webinars. So they managed to mobilize experts from the UK and India and get them ready to share their own experiences and share kind of guidelines and up-to-date evidence. And they did this in the form of 7 webinars, each about an hour to an hour and a half in all. And really, if you haven't seen them, I really recommend them. So that's what they were doing at the same time. And knowing that this existed and that this would contain so much useful information, I think one of the things that we wanted to do together was try and make sure that this information was as accessible as possible. And I think that from our own experiences, we recognize that working in a pandemic, having this information to hand was incredibly useful, but it wasn't necessarily the easiest to attend every webinar. And actually, when you did manage to attend webinars in the evenings after work, you didn't necessarily kind of retain as much as you should have or wanted to. And so I think that's why we decided to make the infographics. So the infographics were aimed to help with making learning more accessible and making distribution more accessible. And I think that was the second point of them, to try and help commonly use social media platforms such as WhatsApp that were used commonly in India, and make sure that we could make something that could also be spread through them. And so the way we structured them, so we did kind of a basic 3-question approach for every infographic. So you can see a couple of the infographics there, but essentially it was, what are the key points? How can this work on the ground, and any other considerations? And given that this is a mental wellbeing and support of healthcare workers kind of day or seminar, I thought it'd be good to kind of go through this infographic just to have a look at the details and look at the structure. So here, in terms of what are the key points, so for every webinar, we looked at kind of what the guidance and what the evidence was actually telling us at this moment in time. And that's basically what we're trying to capture here. We tried to make it as simple as possible, and we tried to make sure that we highlighted anything that we thought was particularly important. So here we're looking at kind of the red section at the bottom is looking at red flags or warning signs of someone struggling with their own mental health and when to reach out. The how can this work on the ground section. So this was all about making sure that we have the evidence kind of above in the key points, but how does this actually work practically? And so it's about making sure that we kind of have some actual advice on these are the things you can do. So here in this section, we outlined kind of what mental health support should be offered or could be offered, and also just talked about other things. So for example, the bottom point was that actually it's not just about the mental health support, it's about making sure that your healthcare workers have the support that they need in terms of training and teaching, and trying to make sure that they can avoid kind of stressful situations in the first place. So using things like breaking bad news workshops and de-escalation technique workshops. And then finally, the other consideration section. So this was kind of important messages that we thought needed to be conveyed, but actually we hadn't covered in the top two sections. So just briefly also to talk about a more clinical infographic, just to kind of show how that worked. Again, what are the key points? We're looking at the evidence here and trying to explain it, but without just having a copy and paste of the guidelines. We tried to just use a few key points to make sure that we covered the things that someone might have to think about. So for example, the bottom right, we just highlighted what were the treatments that currently had an evidence base at the time of the webinar. How can this work on the ground? Again, it was a look into kind of how we can use these guidelines practically. And so, for example, again, bottom right, we discussed the fact that actually the ventilation strategy that you use is not kind of a one size fits all. It's based on your staffing, it's based on the availability of equipment, it's based on the oxygen supply, and actually can change from hospital to hospital. And then once more, the other considerations, just highlighting things that we think need to be kind of thought about when you're treating people with COVID. So the fact that the evidence base of COVID is constantly evolving and is definitely already evolved. So we need to continue to use live guidelines and keep that in mind. And so this is just an example of a few of them. So the infographics were created by Michael Bonar, who's been helping with these, and just kind of all followed this 3-question approach. One thing to mention as well is that we decided to avoid a long list of references and just put a QR code at the bottom for those who wanted to find more information, and that would take you directly to the webinar. In terms of distribution, so we distributed through the SAHF website. We've put the infographics on Twitter. We've sent them around WhatsApp through our networks. And if you're interested, there's a QR code and the website link there. So that QR code will take you to the SAHF resources about coronavirus page. And it's not just got the infographics, it's got the webinars, it's got loads of really good resources. So really recommend that you have a look and see what's there. In terms of further plans, so I think we want to use the infographics just to kind of help summarize SAHF webinars in the future. So a 3-question approach seemed to be enough and kind of covered the points that we wanted to. So hopefully we'll be able to do that in the future. I think it's important also to make sure that we know what we're doing is kind of quality work and that we're doing things that are helpful. So it'd be great to get some user feedback and think about measuring distribution, although it might be slightly different or difficult on WhatsApp. And then we're hoping that we can make further events to collaborate and share these rapidly evolving guidelines and experiences, because I think that's one thing that has come out from the pandemic, that we're doing more collaboration, and it's at least one silver lining. Finally, just a quick thank you. So it was a team effort from everybody. The SAHF Associate Fellows, Harpreet was the one who signed off on all the infographics and made sure that we were covering everything. And Michael was our design expert and Raj was our organisation expert. So thank you.
Brilliant, Anisha. Thank you so much. And I know, utilising the resources myself, just how well received they have been actually. And yeah, I just want to advocate the utilisation of them. So we will make them available to all that are on this webinar today, and right on time. So thank you very much. So I would like to welcome all of our panelists back. And would like to open up the floor to questions, actually, based on all of the presentations and the fantastic work that we have heard this evening. Ganesh has also joined us, who has been monitoring our chat function. So I do have a couple of questions, but I'm happy to open it up to the floor first, Ganesh, and if you want to take us through what's come up on the chat.
Sure. So we'll start. Oh, you can hear me. We'll start chronologically from who started. So we've got a question for Anita from Amal. So is there any collaboration with social prescribing so GPs can refer directly from a consultation?
I think there's pockets of that happening in terms of pharmacy teams working closely with social prescribers, but I think it's early days, and I think there needs to be some clarification of roles. So I'm aware of some pharmacy teams that work within primary care settings, but they work alongside the social prescribers rather than doing the social prescribing themselves. But that's one example, and I guess we need more.
Maybe, sorry, could I just add? Sorry, probably easier for me to be on video. Yeah, so that's really a exciting part of the future post-COVID. So one of the struggles that I really face is in a 10-minute consultation with a patient with mental health issues, and to actively listen and come up with a call to action at the end. That's the main thing. So we usually bring people in after a couple of weeks or a couple of months, but a pharmacist is a very good point of contact to, just check in with a patient or to ask in a very non-medicalized way. And if they have that prescribing ability, then linking that with social prescribing and directing them towards physical activity or gardening classes and things like that would be really beneficial. So I think that it's really exciting what you're doing, Anita, and hopefully we can link it a bit easier into general practice, because a lot of GPs are sticklers for change and won't do anything unless it's made easy as possible for them. So yeah, thank you.
I think there was a couple of other comments in the chat about just that it's a fantastic project, really. So that not really a question there, but just some nice comments.
Thank you. Nice comments.
And then moving on to Deepa and Sally's presentation, we've got a question from Advinda. So how did the children hear about the open workshops, and what methods did you use to engage with them and encourage attendance?
So I believe we disseminated it through Twitter and social media mainly, and also the new community, the comms channels. So we have a new weekly newsletter that goes out, and we have the COVID health champions, which I think they distributed it within their circles as well. Sally, I'm not sure if I've missed anything out. If you know.
So just we've got some young people's champions as well, so they sort of helped us. We've got a network of champions who help us get information out to their sort of peers and things. So but yeah, just social media basically. I went on the first workshop, and I was just really overcome by how many young people wanted to come on the call and talk about their mental well-being, and there was children as young as 8 and 9. It was really quite staggering, to be honest.
Thank you. And we've got another question from Kiran. So how did you measure the impact of the psychoeducation?
So we had, so obviously the New Talking Therapies did the pre-workshop surveys, and then from our perspective, we did post-workshop surveys. So we had basic questions such as, did you increase your learning? What have you gained from the session? What would you like to learn more about? So just a general evaluation feedback is how we measured it. But as it was a pilot session, we didn't go too in-depth with the questions. We just wanted to get a bit of a feel about if this is what they wanted, and in fact, it wasn't. So that was quite helpful.
Sure. And the last question from the chat was from Amal, who said, Newham had one of the highest rates of COVID infections during the peak. What would be the #1 biggest learning point from a local public health perspective to prevent this in the future?
So I'll take that one. So, I mean, yes, it was interesting actually, because as cases were starting to appear in the first round of the pandemic, we were the last borough in London to actually get a case, and we were watching and thinking, you know, any minute it's going to be us. And it was, and ultimately in that first round we had the highest level of deaths and things, which was, you know, dreadful. The Newham factor, basically we have, you know, as Deepa sort of described our community, we have, you know, really high levels of deprivation. We've got high levels of multi-generational families. A lot of people who, if they are employed, they're employed in the sort of high risk frontline occupations, you know, taxi drivers, bus drivers, carers, people like that. So, you know, we had all the sort of high risk factors. We've worked really hard with the community to try and protect residents as best as we can. And there's, you know, as I said, you know, Newham is a place that's got the most amazing sort of community assets as well. So what we've done is, I mean, we've had sort of testing opportunities all over the borough. We have worked hard to really understand why people won't isolate and don't isolate. So we've got all sorts of different packages of support in place. So you know, people can go to a hotel and isolate away from their family now in Newham, which is quite unusual. You know, not all boroughs do that. We've worked really hard with multi-faith forums in the boroughs and things. We've still got our challenges. So vaccination in the borough is incredibly low compared to the national levels. So we're working hard on that. We've got a mass vaccination event at the London Stadium on Saturday, which hopefully, you know, we'll see 10,000 people, young people, through for their vaccination. But I think on the lessons learned, I think it's that bit about really working with the community and, you know, getting them to help us and interpret how we deliver that support, basically.
Thank you.
Thank you, Sally. Sorry, guys, one more. I think you've done an absolutely brilliant job in Newham, especially with the culturally specific work. And I just had one further question about the mental health. Just linking it back to mental health. I've had a few patients who do have quite serious mental health issues, who are absolutely reluctant to take the vaccine. And this is the patient population who are most vulnerable, and through misinformation have made their minds up that this is not something for them, and they're so highly impressionable. And I do not know what to do. And I've been absolutely stumped in my consultations because they just would not, they've got this huge barrier up. And I just wonder if you had any, from your, I know that you're very experienced with your background, if you had any advice or any initiatives that's happening in Newham that might be dealing patients with serious mental illness and anti-vaccination kind of myths.
So what we've, I mean, what we've tried to do, and it's not 100% successful yet, so, you know, I don't want you to give you that impression, but we've got our secret weapon has been our COVID champions. So we've got, I think it's about nearly 600 COVID champions now who are from all sorts of different backgrounds and different communities. And some of them have put themselves forward as peer supporters for vaccination. And basically, the way we've sort of really got through some of those challenges that you're describing, Amal, is to really get those peer supporters to help us, talk to those people, work with those people, you know, show by using community champions or community faith leaders or whatever, and really just try and work in that way to try and break it down. We haven't been successful completely, but it has worked very well. And the other thing has been combining that with pop-up vaccination sites, so in places that are trusted. So a lot of our different temples and faith settings have had pop-up vaccination sites in there, and that's worked well as well. And it's just, as you say, it's breaking down some of the myths, isn't it? We've got some videos that we could use which tell people stories. I don't know if you wanted to use those, but yeah, we've really worked hard on it.
That's great. Thank
Just
you.
to add, actually, we've seen quite a lot of decliners recently with the vaccine. So what we've done is we've sent letters out to GPs directly, to various practices, and informed that they can directly refer a patient who is a bit hesitant about their vaccine or has declined their vaccine to speak directly to a peer supporter, so they can actually coach them in more time, rather than the 10-minute consultant that the GPs have, spend more time speaking through their worries and concerns and kind of coaching them through that, so they feel a bit more supported.
That's brilliant. Yeah, we need something like that in Birmingham. Thank you.
So I think that was the last question, but there was some very nice comments again, lots of praise. In terms of the final presentation from Anisha, so we've again had some lovely comments, but no specific questions. So I'll pass it back to Kiran and open it up to if anyone from the panel has got any questions.
Yeah, thank you very much, Ganesh. Yeah, so I think I wanted to take the opportunity to thank you all really for your time this evening and sharing some fantastic examples of practice within each of your prospective areas. And I think it's been really insightful in terms of how you have actually addressed some of the challenges with regards to mental health and some of the inequalities that we know have been quite stark across the frontline workforce, but also the experience within communities, I think, has been really fascinating to hear about in terms of the work that you've been doing in Newham. There probably still is so much more that we can do collaboratively, and I think SAHF are committed to looking at new ways of working and thinking. But I think the insight from this evening's webinar has been particularly useful, and I think will help some of the forward planning into our next series of webinars. So was there any further questions from either any of the panel members about this evening's presentation? If so, please do kind of shout now. Otherwise, I'm happy to bring the seminar to a close.
Could I just say one last thing, Kiran? The spirit of the fellowship is actually this collaboration, and it started from this vision of uniting people on this joint passion for reducing health inequalities during the pandemic. And I think the work that's been done with the COVID in India infographics really, materialized that vision. And if anybody's attending who wants to be involved in this incredible team, make sure you get in contact with us, because I think that it is the strength in this multidisciplinary approach on this common vision that's really going to make some changes. So yeah, thanks to everyone for attending.
Brilliant, Amal, thank you. And just a couple of points that I need to raise. So I have been reminded to tell you all that everybody will receive a certificate of attendance for this evening's webinar, and there will be a survey link sent out to all of the participants and all of the delegates that we will encourage you to complete so we can obtain some feedback. And this session has been recorded, so it will be available on the SAHF website for those that weren't able to join, but also those that would like to listen back and hear all of the wonderful presentations that we've had. So from me, thank you to everybody. I hope you've enjoyed it. I think it's been a fascinating evening, and we'll see you in the next one.